So I have a short talk today. My topic is postoperative adjuvant tomotherapy following radical pleurectomy for malignant pleural mesothelioma, and this is an assessment of toxicity. It's an analysis of the combined UCLA and Hoag experience. So Percy Lee will be speaking about this same topic after me, and then my other collaborators are Olga Olevsky and Robert Cameron. So we know that mesothelioma is a local disease. Local control remains a predominant problem, and failures are most commonly in the ipsilateral lung field, as we can see in most surgical series, and the numbers are high, maybe even higher, depending on how you look at the numbers, as Dr. Cameron has talked about this morning. Our surgical options are extrapleural pneumonectomy or a pleurectomy decortication. We know that neither technique will lead to an R0 resection, and so there's definitely a rationale for local adjuvant therapy. Some advantages of a pleurectomy decortication would include a lower morbidity rate, and at least in some series, there's a suggestion of improved survival with a PD as opposed to an EPP. However, there's one potential advantage of an EPP in that it does make it easier to give adjuvant radiation. And if you look at the NCCN guidelines, again, just quoting from the 2015 text, they state this: for patients with resectable MPM who undergo EPP, adjuvant radiation can be recommended for patients with good performance status to improve local control. However, radiation after pleurectomy decortication is usually not recommended, and they cite that the toxicity is significant. So if you look at the literature that's quoted, it comes from really this paper from Sloan Kettering, looking at hemithoracic radiation after pleurectomy decortication. They had 123 patients treated with radiation with or without brachytherapy. And indeed, you do see a 28% rate of grade 3 or 4 toxicity. And this includes 10% of patients with severe chronic pulmonary symptoms, 6% with grade 3 or 4 pericarditis, and even 1.6% who died from toxicity within 1 month of treatment. Now, if you look at their techniques, you can see why this disease is so challenging to treat with conventional techniques. What we'd like to do is treat all of the pleura in the hemithorax, including part of the mediastinum, but our problem with treatment with typical APPA fields is that there are a lot of critical structures that are in the way. So to treat, you'd have to block the spinal cord, you have to block some of the lung parenchyma and the abdominal structures, and you can try to make up some of this dose with electrons. The problem is even worse on the left side, where you have the heart to contend with. And ultimately, you have a treatment strategy which is, to be honest, not very satisfactory, both in terms of tumor coverage and also with avoidance of sensitive structures. So is there a better way? Well, in 2005 at Hoag, shortly after I finished residency at UCLA, we introduced tomotherapy, which is a radiation machine which marries the technology of a CT scanner with a traditional linear accelerator, and it delivers a form of radiation called image-guided helical IMRT. The advantages of tomotherapy include the ability to get a three-dimensional image with the patient on the machine prior to treatment and adjust for that so that we have very precise positioning. And also the helical delivery of radiation allows for an infinite number of beam angles, and so we can really achieve a much more conformal radiation dose distribution than was possible previously, and also create some very special shapes of radiation within the body. So after we got this machine, it immediately became apparent that there would be some advantages for the treatment of mesothelioma, where we have a target volume which is really an annulus or a rind of a tumor around the pleura, and we want to spare the underlying lung lung parenchyma in the center of that rind. And so we developed a technique, and this begins with immobilization in a body fix bag here. We use a modest amount of suction to regulate the breathing cycle. I always put myself in this picture to show that it looks a little funny being a human burrito, but it's actually fairly comfortable. We still do a 4D CT for planning to take into account any respiratory motion. We use an IMRT inverse planning with the goal of delivering 45 gray to the target volume. And what we can achieve then is a dose distribution which is able to concentrate radiation around the pleura while sparing other structures like the contralateral lung and the spinal cord. And so, can tomotherapy safely treat the intact lung? Well, we sought to answer this question by looking at our patients treated at UCLA and Hoag. They all received postoperative tomotherapy following a radical pleurectomy. And here's a breakdown of histologies. The majority were epithelioid, but we did have a fair number who were biphasic or sarcomatoid, fairly evenly distributed between right and left-sided tumors. Here's the staging of our patients, the majority having T3N2. And looked at another way, we had a fair number with no negative disease, but the majority were node positive, and the vast majority had N2 disease. Radiation was given 62 days plus or minus 40 days with a wide range from 36 to 224, which was variable depending on how long it took a patient to recover from surgery. And the target volume dose was 45 gray in the majority of patients, with our PTV being the ipsilateral hemithorax. We used a 5 millimeter inner margin on the pleura and a 10 to 12 millimeter outer margin. We did not attempt to target the interlobar pleura, and we typically included the surgical tract and any hilar or involved mediastinal lymph nodes. We also had 3 patients, which ended up being about 10%, who also received a boost to about 60 gray, and these were in cases where there was either a recurrence or gross residual disease left behind following surgery. So the 31 patients treated, the majority did have some form of toxicity, but 90% were low grade, 1 to 2. The most common being fatigue in about 2/3 of patients and skin erythema, both of which would be expected given the large volumes of treatment and also the need to treat the surgical tract out to the scar. We just had 3 patients, or about 10%, who had grade 3 or greater toxicity and were hospitalized. And this include 1 grade 3 shortness of breath, 1 patient with a grade 3 esophagitis who was diagnosed with Candida, and then 1 grade 5 shortness of breath, which was confounded by an early tumor recurrence. 2 patients required a treatment break. 1 was a patient who had esophagitis and another patient who had nausea. And 1 patient had their radiation terminated early at 32.4 gray because of shortness of breath, and no patients died from radiation toxicity. And so here's a greater breakdown of the grade 1 and 2 toxicity that we saw, again with the most common being fatigue, some patients with respiratory symptoms, nausea. The dysphagia and esophagitis rates were what you might expect for single modality treatment of a lung tumor. Some patients also with chest pain. Again, these patients have had thoracotomy, so that also may confound that toxicity. And so in conclusion, we found that adjuvant tomotherapy following radical pleurectomy decortication is safe with manageable toxicity in greater than 90% of patients, rarely requiring treatment interruption. And now I'll hand it over to Percy.